What we want to do now is get some sort of overview on diabetes. Now, diabetes is actually an old-fashioned word that means polyuria. Technically, it comes from a word that means to siphon water out of the body. So diabetes describes large volumes of urine. And there's actually two conditions where this happens. One's called diabetes mellitus, and one is called diabetes insipidus. And they're two completely separate diseases. It's a bit of a pity they've got the same name, really. But in diabetes insipidus, there is a lack of antidiuretic hormone. Now, you might remember that antidiuretic hormone increases the reabsorption of water from the renal tubules. If you increase the reabsorption of water from the renal tubules, what's that going to do to the amount of water in the urine? Well, it's going to reduce it. It will reduce urine volumes. So antidiuretic hormone has an antidiuretic effect because a diuresis means an abnormally large volume of urine. So lack of antidiuretic hormone will result in a polyuria. But the urine tasted insipid. It's diabetes insipidus. It's a watery diabetes, a watery polyuria caused by lack of antidiuretic hormone. And these days we can treat this by giving synthetic antidiuretic hormone, or sometimes called vasopressin. Vasopressin is actually an old-fashioned name for antidiuretic hormone. But I'm only mentioning this because this is nothing to do with what we want to talk about. It's nothing to do with diabetes mellitus. Diabetes mellitus means sugar diabetes. Mellitus or mellitus means sweet. So in this case, you get a sweet polyuria. The patient produces a large volume of urine and it tastes sweet. These days, I'm pleased to say, we don't have to taste the urine because we have dipsticks now. But there's two completely different forms of diabetes mellitus, and these are simply called type 1 and type 2 diabetes mellitus. Now, type 1 diabetes mellitus used to be called juvenile onset diabetes mellitus. And this is still a reasonable description of the condition because most cases present in young people. It has a juvenile onset. So the patient might be 12, 13, 14 years old when they present. That would be fairly typical. Juveniles present with it. But it's not an overall description because younger children can present, even babies can present, and adults can present with the condition as well. So diabetes mellitus type 1 can present at any age. It's just most common in the juvenile years. And it's always an insulin-dependent diabetes mellitus. The patients are always dependent on insulin, an insulin-dependent diabetes mellitus, IDDM. Without insulin, these patients will not survive. They must have insulin. And the reason for this is that they have stopped producing any of their own insulin at all. So in an established case of type 1 diabetes, the patient produces no insulin. And the reason for this is that the beta cells in the islets of Langerhans in the pancreas have been completely destroyed. And we now know that probably in virtually all cases, if not all cases, this is an autoimmune disease. It's now clear that this is an autoimmune disease in probably virtually all cases of type 1 diabetes mellitus. And we know this because if you take biopsies of the pancreas, we can see that the T cells are mediating progressive autoimmune destruction. We can find other inflammatory cells. There'll be macrophages there, the body's own defense cells. There'll be B and T lymphocytes, natural killer cells, which are destroying the body's own beta cells. It's a terrible mistake. It's an autoimmune disease. The immune system has got it wrong and is destroying its own beta cells efficiently, meticulously, ruthlessly, absolutely destroying the beta cells. Strangely, not affecting the alpha cells at all, not at all. And this process takes several years to develop, actually, because clinical features only present when 70, 80 or 90% of the beta cells have been destroyed. So I guess there's a lot of spare beta cells, but it's only when a lot have been destroyed that presents. And the destruction of the beta cell mass could take Well, I guess several years, a year or more, several years. But only when 70 to 90% are destroyed do clinical features present in type 1 diabetes. Going back to diabetes generally, a way to think about diabetes is that the blood sugar levels rise, of course. And the World Health Organization say that if the blood sugar levels rise above 7 fasting or 11.1 random blood sugar levels, then we should consider diabetes. So in other words, if someone hasn't eaten for 12 to 24 hours and the blood sugar levels are 7 or above, that will be abnormally high. And if you take a random blood sugar level, someone's blood sugar throughout the day, and you find it's more than 11.1, again, that would be abnormally high. And indeed, glucose in urine is always abnormal. If there's glucose in urine, usually that means that the renal threshold has been exceeded. And the renal threshold in most people is around about 11 millimoles. So what that means is the kidneys can absorb up to 11 millimoles, but more than that, they can't reabsorb. So if the blood sugar is 14 and the kidneys can only reabsorb 11, then some glucose is going to be present in the urine. So if we find a glucoseuria, again, that's an abnormal finding, and we can respond to that by doing a BM, a blood sugar measurement, and we'll normally find out that it is in fact higher than 11 in diabetes. So going on to still thinking about type 1 diabetes. Let's think about the causes of it. What's causing this? Well, there's a genetic predisposition. There's several different genes that have been identified, but what we know is that monozygotic twins, identical twins, the concordance rate is about 35%. So if one identical twin's got it, there's a 35% probability the other one's got it. Dizygotic familiar twins is around about 20%. And even brothers and sisters, it can be as high as 16%. And what seems to happen is if a father is diabetic, there's about a 9% chance any children will have diabetes, type 1. We're talking about type 1 here. If a father has type 1 diabetes mellitus, about a 9% factor probability a child will be affected. For the mother, it's fairly low. It's only about 3%. But if both parents are diabetic, have type 1 diabetes, then the probability that any children will have it is about 30%. So there's a fair environmental effect, fair genetic effect here before we think about environmental things. So a genetic predisposition. Let's think about environmental causes. What's become popular over the past few years is the hygiene hypothesis. Now, the idea here is that many young children are kept in very clean environments, and they don't come into contact with soil bacteria. And it seems that exposure with bacteria should be part of the normal rough and tumble of childhood life. So if children come into contact with soil bacteria, that educates their immune system. It trains up their immune system to tell the difference between what is foreign bacteria that they should be making antibodies against and what is part of their own body that they shouldn't be making antibodies against. So it appears that children that are kept too clean are more prone to this type of autoimmune disease. Viruses can be a trigger factor. Various viruses have been infected: mumps, Coxsackie viruses, cytomegaloviruses, viruses, different types of viruses. What might happen here actually is the virus might just be a trigger. So the virus would trigger an antibody response, and because the immune system is not responding normally, the immune system would also produce abnormal antibodies against the beta cells. Vitamin D, interesting. After the Second World War, they started putting vitamin D in baby foods because of rickets. But then they took it out because they were paranoid about it causing, allergic reactions or something in a very, very small minority of children. And in the last 10-15 years, the incidence of type 1 diabetes, well, for 20 years now, has been significantly increasing. And it now looks like lack of vitamin D in early childhood might be a significant factor in the etiology of type 1 diabetes. So children with relatively low levels of vitamin D, not low enough to cause rickets, but relatively low levels of vitamin D, do seem to be much more prone to type 1 diabetes. So I guess we should start letting our children kick around the garden where they come into contact with soil, and I guess we should start giving them extra vitamin D. But what we mustn't do in the first few months, probably 6 months, a year of life anyway, is give them cow's milk. Bovine serum albumin in cow's milk is bad for them. Again, it can trigger off these autoimmune reactions. And we shouldn't be giving them cured or smoked meats, and we shouldn't be giving children coffee either. All these things have been they're not proved to cause type 1 diabetes, but they are associations and things best to be avoided.